Welcome. I'd like to introduce our guest at the AWE conference, Dr. Joe Elmunzer from MUSC. Welcome. Thank you for coming here and displaying this EUS guided transluminal access that we use in daily practice for access of many different transluminal structures. And we're going to focus on access of the common bile duct, but Dr. Elmunzer, you want to discuss some of the other aspects of this technique?
Well, thank you so much for having me. It's an honor to be at, I think, the 7th annual AWE conference. I've been jockeying for an invite for a long time, so I'm really excited to be here. But yeah, so to your point, I mean, there are a lot of clinical indications, particularly over the last few years, that have evolved in terms of EUS-guided deployment of aluminum-opposing metal stent. Started with pancreatic fluid collection drainage, and then a lot of people use it nowadays, and it's FDA approved for gallbladder drainage, but we also use it for abscesses and draining the bile duct, direct drainage of the bile duct for EUS-guided gastrojejunectomy and gastric outlet obstruction, and then commonly for a procedure called EDGE to facilitate per oral ERCP in patients with Roux-en-Y gastric bypass. So those are the most common indications. Typically.
I call it the grand slam of EUS-directed therapy.
When you do all of that in one session.
Right. Okay, well, we're going to get started and demonstrate how we do this technique. Dr. Elmunzer has a simplified way of explaining it.
Well, that I don't know about, but certainly we've been doing these for a long time. And so typically, the first thing to ensure, right, is that you're in the most optimal position and that your target is large enough to accommodate the deployment process of the stent. Because during that deployment process, the leading edge, what's called the nose cone, is going to sort of move forward and potentially push you backwards. And so you want to make sure that that's not going to push you out of your target structure. And so part of that is making sure you have enough working space on the other side, but part of it is ensuring that you are stable enough and you're not easily going to fall back. So that's the first step, is you want to be relatively stable. Then the next thing we typically would do is check Doppler. We're not going to do that in this sort of animate model, but in this non-live model, but you would check Doppler. Typically what I do, I don't know what you do, Mary Lee, is before actually stepping on the pedal to burn through, I typically turn the Doppler off because I think the artifact can be really distracting.
I agree.
And you ideally want to see yourself puncture through as clearly as possible. So for the sake of discussion, we'll say that we have checked the Doppler, that we don't see any interceding vessels, and then we're ready to go. And so the first step, for those of you who aren't terribly familiar, is you would unlock what's called the catheter hub, and then you would advance the nose cone, which is the deployment catheter that contains the stent, to the wall. And in this case, if you guys are seeing the screen as well, we have I'm going up and down with the elevator just to demonstrate a little bit of movement with the tip of the device. And again, that device has the prosthesis within it, right?
And Joe, is there any distance that would concern you if it was too thick or too thin? That would be a difficult challenge to get when you get into the orifice?
Well, in principle, right, if the wall that you are traversing is terribly long, then there's a chance that you will likely make it in. There's a chance, though, when you deploy, that you will deploy the proximal, the closer flange, into the wall and then get a maldeployment. So you have to be somewhat thoughtful. I mean, part of the concept of the aluminum-opposing metal stent is that when you deploy the far flange and you pull back, it should bring everything toward you and shorten that distance, but that doesn't always work out perfectly. And so I think that's the rationale behind the 15 millimeter length, so to allow for a little bit more distance. But at some point, if it's super far away, then I think you have to reconsider, the indication, the judgment in general. So if it's beyond 15 millimeters, you measure that beyond 15 millimeters, I think you have to think twice about the wisdom of doing that, and consider the risk-benefit ratio and so forth.
And then the extraluminal structure that we're entering, we also want to have a distance that's adequate for the stent to be deployed into as well.
Yeah, absolutely. Again, you need that working space because the nose cone is going to move forward and potentially push you back if it's up against the contralateral wall. And so you have to be really thoughtful about that. Now, we have more latitude now that there are different sizes. So with the 6 millimeter prosthesis, for example, we might be able to puncture a really small target. But you really have to be, I think that the number one reason for maldeployment is that there's not enough working space within the target.
Absolutely.
So just moving forward, so we're going to advance the tip of the catheter until it sort of tents the target wall. And then once you're in position and stable, you've excluded an interseating vessel. One thing that as those of us who have done FNA for a long time is our natural tendency is to sort of puncture through, is to pop through. And this is fundamentally different. The concept here is that you want to step on the pedal for a short period of time to allow the device to heat up and the tissue to heat up. And then you're going to advance it more slowly, like almost like a hot knife through butter, in order to sort of burn your way through and minimize the likelihood of pushing the target structure away.
Exactly.
And so typically you wouldn't hook up until you're ready, but we're hot now because we're ready. And so what I'm going to do, and again, our tendency is to puncture through just because of FNA. So we're going to be, we're going to be really disciplined about the fact that I'm going to step on it for a split second, let it heat up, and then I'm going to advance slowly and steadily. And then what we ideally want to see on the screen is the bubbling effect of the heat within the target fluid. And once you do that, once you see that, then you know you're in good shape. So I'm tenting the target, I'm going to step, and we're gonna let it, so I went through a little faster than I normally would, but we're gonna go through nice and steadily. And then typically if you have enough room like this, you could just go as far as you need to, as long as you know that the wall is not on the other side. And once you're there, and then, so we'll unhook for safety reasons, you can lock your catheter hub. So one question that comes up, Mary Lee, is whether you need this preloaded with a wire, right? So a couple things I'll say about that is, and we learned this the hard way, the commitment to always having a wire and pushing it into the target structure for safety reasons, that turns out not to be the best for every single situation, particularly if the working space is small or it's very mobile. With the wire, sometimes you can push yourself out. And so, for example, in my practice for EUS guided gastrojejunostomy, I typically don't preload with a wire. I typically don't preload with a wire, but in some cases it's helpful. So we're here and
Joe, what are the specific cases that you might consider using a wire in?
I think, so a wire is always going to be helpful because typically you're going to dilate the lumen, right? So like, for example, in a pancreatic fluid collection drainage, I typically preload with a wire, burn through, and then advance the wire, coil it, and then dilate. I think with edge, if you have a big working space, I think when you're worried about the size of the working space, I think a wire, particularly if you're going right against that contralateral wall, pushing the wire out can push the device closer to you, which might lead you to fall out. And then the other thing to consider briefly is that tip of the device actually jets out quite a bit. And so even if you don't have a wire, even if you're mal-deployed, often that tip is in the structure, so you can always load a wire after the fact. So anyway, so we're in good position, we're happy. I think we're far enough into the target. The catheter hub is locked. So now we're going to unlock the stent deployment hub. And we do that by removing the protective
yellow flap.
Stupid thing I call it, but yeah. And then we will unlock the stent deployment hub. And then this process is ideally done under direct visualization, and we're going to deploy by bringing our fingers together. And so as we do that, if you look at the screen, and you'll see the tip does move away, and that's what we have to be cautious about. But as you do that, it'll start to deploy. Now, one thing, if you don't have a lot of working space that's worth mentioning, is as you do this, you can actually work in a limited space by milking the tip out and sort of exchanging. And the way you do that is as you deploy, you can push the stent deployment hub back toward its original position, and that won't reconstrain it completely. It'll partially reconstrain it. And so if you repeat that process, deploy a little bit and then push out, and redeploy a little bit and push out, it actually allows you to milk it out in such a way that does not send the tip of it really far out. But eventually we will deploy and hopefully see it completely open up. And once we've done that, then we're really happy. We know we're in the target structure. And then the question becomes the next step, how to ensure that we deploy the proximal flange on the luminal side. And in my experience, the best way of doing this is unlocking the catheter hub and then pulling back on the stent. And some people talk about the deformity of the actual stent, but what I typically use is, you'll notice there's that white line in the middle of the prosthesis, and I actually pull back until that white line is almost touching the lateral aspect of the prosthesis. So I like that sort of angle to be almost gone. And once you achieve that and lock your catheter hub again, then I think you almost always, regardless of the distance, have enough proximal flange in your channel. Traditionally, when we first started doing this, we would try to do the second portion, the proximal flange, endoscopically. So we'd back out endoscopically, looking for a little bit of that black marker on the catheter itself. I think many people have observed that that actually makes it a little bit more less stable, and sometimes you fall back when you do that. So I think people observe maladeployments. So what I almost universally do is that I will deploy the proximal flange in my channel.
So this stent, we have a dumbbell-shaped stent. We just deployed the distal flange. Now you're about to deploy the proximal flange. And in between, we have, what, a 1 centimeter
Yeah, one or
space,
one and a half centimeters saddle, yeah.
Right.
And so that saddle will be deployed hopefully across the tract and partially in my channel. And then the proximal flange dumbbell will hopefully be completely in the channel. And then once you're there, you're golden. Once you're there, you're golden, and then you could just cautiously expel the intraluminal flange. So let's do that. So the catheter hub now, the stent deployment hub locks automatically after the first distal flange deployment. So we'll unlock it again, and then we'll just slowly deploy into our channel. And so once we've done that, we won't get any tactile feedback or anything, but once that's done, we should be pretty confident that we are deployed in our channel. And so the next step is basically to back away and expel the intraluminal flange that's currently in the channel. Now typically that can be done by unlocking the catheter hub, backing away a little bit, and then pushing out. And usually you're able to back away enough, rotating and backing away to do that. But for those who may not be familiar, if you look at, I don't know if you guys can see the handle here, there's a little notch right here, and that's almost like a plunger. So if you find that you brought your catheter hub out and it's still not deployed, then you can actually use this notch to plunge everything out, and in principle the combination of those two things should lead to proper deployment.
That's definitely an important trick.
Yeah, so we'll see if we can do that. So we're going to push the catheter out, and then we'll use the plunger to get the rest of it out, and then we've deployed successfully. And then sonographically you can see the saddle across the wall, and again this sort of nose cone catheter, that's in the target, so you're totally fine now to advance the wire through if you want.
Thank you so much, Joe, for this excellent demonstration of Axios deployment. Thank you.
Well, thanks for having me.